भरोसा नहीं मुझ पर?
डाउट है तो वाइप करो Savlon Germ Protection Wipes.
Hello and welcome to Expressions, brought to you by the New Indian Express and Savlon. Thank you for joining us, Dr. Chandrakant Lahariya. He's one of India's leading physicists and public healthcare analysts and researchers. And I think that's very significant in these current times, because we need people also, while they are involved in the pandemic, we need people also to step back a little and tell us what are the lessons that we can learn from this pandemic, which we can then use in our public health policy and get these things sorted out for once and for all, so that when another pandemic hits us, and for sure all the signs are that it will. May I just get started right away and talk about what really were the lessons of the first wave, which we didn't quite analyze properly and didn't include in our response to the second wave?
We know that pandemics are a reality of our times. And now we are in the middle of the second wave. So there are many of the lessons which we can learn from both first wave and second wave to prepare for future pandemic epidemics. And one of the key lessons is that there is no alternative for a good preparedness and response for the pandemic. You cannot prepare for the pandemics when you are in mid of one. You have to prepare in advance, and that's the only way. And second part, a linked part to that, is preparedness and response, is that you have to have a surge capacity. Surge capacity means some additional capacity which you can immediately mount to have a response. That's one. Second is that pandemic can only be fought with the knowledge and evidence. And this knowledge and evidence will come very in quick succession and need to be used for policy making. And that is also linked to that if you want to fight pandemic really well, it cannot be administrative and bureaucratic response. It has to be guided by technical experts as well as independent experts. So that's the second part. Third learning which we learned, that pandemic response required three-way partnership. What is three-way partnership? It required partnership between policymakers and bureaucrats. That's one group. Second is a technical expert, both health and medical expert. And third is community. World over, we have studied in the detail that it required good coordination between three groups: policymaker, technical experts, community. If any of them is not working in tandem, it will not be effective. The fourth lesson is that it requires decentralized operationalization. So while a broader policies can be designed, but operationalization has to be decentralized. The other lesson, fifth lesson in my opinion, is that to fight pandemic, you need to have a reliable and timely data. If you don't have data on which is really sufficiently granular, it will not work. So we need to have that kind of this thing. And final lesson is, and which many countries and many setups made a mistake, that there will not be a winner in the pandemic till pandemic is over from all parts of the world. There cannot be best practice, single best practice, or a success story till we are in the middle of the pandemic. And if we had known or used some of these, we would have been better situation than we were at the peak of the second wave.
Now that we are in the peak of the second wave, and you already hear that we will soon be in the midst of a third wave, what are the things that we can do now?
Well, so now we have burnt our fingers and we have learned in a little better way. So one is that we need to prepare really well. And prepared means a detailed planning, which had to be a midterm, or even we can say short term, a month ahead, a midterm, which would be 3 months in this case, and long term. And this kind of planning is required at the national and state level, both. The second lesson or second learning is that we need to look around the good practices, which some of the states and districts adopted, and those need to be implemented. Third lesson is that we know, and currently we are in the mid of the second wave, and we know that there is not sufficient data from rural India. So we need to improve the data recording and reporting system, but we also need to improve the testing services in the rural area. We need to improve the like vaccination and the treatment services in the rural areas. So focus had to be for the third wave had to be rural area. Fourth part is that as we utilize the data, while we need to improve our recording reporting system, some of the genomic sequencing need to be expanded and more data need to be collected, because that's how we will get a sense of the new and emerging strains of virus. Another aspect is that we need to have a really improved vaccination plan and strategy for the country. We can go on and discuss in the detail that what are the challenges in vaccination, but we need to remember that we need to really plan for vaccination. Two parts. One is that we know there is a short supply in the vaccination, the vaccines from June and July. So a different type of plan is required. And once we know that there will be enhanced vaccine delivery or vaccine availability, a separate kind of strategy that how that enhanced availability will be utilized for which population, how it will be distributed between the state, and all those need to be done. I would like to flag a few relevant points, and these are the last two parts. What we have learned and what we know, that in COVID-19 pandemic, there are many people who would now have a post-COVID situation. So we need to scale up our post-COVID clinics and setups. And other dimension of this is that there are going to be mental health challenges in the period ahead. So these two are the clinical and public health areas which should be given attention. And final part, we at the beginning of the pandemic heard a lot of discourse that India need to strengthen health systems and health services. But what we know that in the months to follow, it was merely reduced to increasing beds, ventilators, and limited testing services. The concept of health system was not fully understood. It was a great opportunity. India faltered on it. And then during the period of low transmission between November 2020 to February 2021, nothing was done to strengthen health system. So now we have seen what happens when we don't prepare. We see that what happens when health systems are not ready. That is one overarching lesson which we need to follow for the third wave and the period ahead for the country.
Now, Dr. Lahariya, let's just break this down a little. We'll just come to vaccinations, but I want to ask you now. Most of India has been in lockdown for between 6 to 7 weeks, across the board. In different states, there have been different numbers of weeks. Now, I want to ask you that, do you think we've built enough surge capacity, as you were saying, and the right kind of surge capacity? You said beds and oxygen is not enough. You need to have oxygenated beds or whatever it is. Please do let us know what it is that we need. Have we done that in the past 6 to 7 weeks when, again, we went through quite a strict lockdown?
No. Simple answer is that we did not do enough which was long-term and sustainable. It's true that there were some of the beds which were repurposed conventional or usually available beds in the government facility to COVID-19 beds. There was some attention on ventilators. It had to be acknowledged that there was a testing capacity for COVID-19 which was increased and which was standalone, and PPE production capacity was increased, but nothing major to increase the health system capacity which can be sustained for the longer period. Most of the things which were done were temporary, and we know through temporary COVID care facilities and centers, which at times were dismantled by January 2021, February 2021. That's one. Second thing is that much of the pandemic response in the first wave was dependent upon private sector participation, where the banquet halls or hotels were converted into bed, which was the right thing to be done. But the right thing to be done at the ad hoc basis. When we know that this kind of challenge is still around, the subsequent period, once first wave was over, it should have been utilized to strengthen actual capacity. That was not done. We know that much of the second wave pandemic response, the government facilities hardly had sufficient number of beds or even the functioning bed. Much of the response has come from the private sector facilities and beds which were repurposed, and we know that how much people have suffered, how much people have paid from their pocket for this thing. The situation in the second wave is a reflection of our insufficient attention and actions taken during the first wave. So there has not been done anything which can be said long-term sustainable, which can be said health system standing. Of course, actions were taken to repurpose, and since it's a non-COVID essential services, but the only other services which were available, people delayed their regular healthcare seeking. So there was some free capacity with the health system. Only that was purpose for COVID-19. But we also need to be mindful that in the period ahead, when people have not used those kind of services for non-essential emergency services, which have not been used. So people with diabetes, hypertension, other conditions. Now, once this pandemic would be over, they would start coming to healthcare facilities. So healthcare facilities will be overburdened. We need to expand and increase the capacity and think of a long-term vision. COVID-19 is not going anywhere. Some of the services will be required. Of course, in the mid of the second wave, that kind of attention or that kind of priority cannot be done. But sooner the second wave is over, it will be time for re-examining the health system needs for Indian states. Each of the both central government and union government, both central government and state government need to look and examine that what need to be done. If governments do not act now, then question would remain that when they will act.
And now, Dr. Lahariya, we've seen that, as you said, these beds came up on an ad hoc basis. So did the staff. Most of them were employed on contract. Now, what has happened is within the district hospitals, rural hospitals, you don't have the kind of capacity that you should either in human resources or in oxygenated beds. And even if oxygen cylinders are available, you don't have people who know how to operate them. So why it is a very simple thing that is obviously staring the government in the face. Why are these institutions, the district hospitals, the primary health centers, why are these not being strengthened?
So that is a challenge of Indian healthcare system, which has, or other, let me put it different way. The Indian healthcare system has been ignored historically and traditionally, while there has been a number of political promises through various policy formulations, such as National Health Policy of 2002 and the National Health Policy of 2017. But those political promises have never been followed through. We know that soon after the policies are released, the political leaders make big announcements and entire mileage out of the political announcements is taken, and then there is no additional advantage for policymakers. Apparently, there is no additional advantage for policymakers to follow through on those practices. Otherwise, how else do you explain that those policy promises are not followed through? As an example, in 2002 National Health Policy, government announced that the government spending on health would be increased to 2% of GDP on health. And that was for year 2010. But we know between 2002 and 2015-16, it increased marginally from around 1% of GDP to 1.15% of GDP.
Right.
Now, in 2017 policy, just to give another example, that just in 2017 National Health Policy, the government made announcement that now health expenditure by the government would be increased from 1.15% of GDP to 2.5% of GDP by year 2025. Now, right now, we are in the middle of that point in 2021. However, in the last 4 years, the government spending on health has increased only by 0.15% of GDP, even if we go by budgetary estimates. So that is insufficient to achieve those goals. So it is really lack of political will that is reflected that even the policy promises made at the highest level, approved by highest authorities, are not followed through. I would like to finally add this part that this is not going to change. Health is not a political, this is not going to change unless there's something more else is done. And what something else that is health should become a political priority and election agenda. And I think it is very relevant, imperative from political and citizens' perspective that citizens start demanding health services from the government. And that is the only way it will change.
Doctor, all the oxygenated beds that have come in, all the aid that has come in, it has gone to perhaps these ad hoc centers. Cannot those be now repurposed from those ad hoc centers to the district hospitals and primary health centers?
So here the truth is that in the routine healthcare service, we might not need that many oxygenated beds or that many beds. What people need hospital beds when they are sick, they need to be admitted. What we know that health services and government system are insufficient. So when people come to those government healthcare facilities, there are not availability of beds, so they have to choose for private sector. So it's not merely about hospital beds which are oxygenated, but it is more about the hospital beds and services. But I also want to bring another
Government,
dimension.
you mean the public hospital?
I also want to bring the second part, which is that merely having a bed is not enough. It's linked to the healthcare providers. Health workforce is not available. Then medicines are not available. Then referral linkages are not available. So when we start looking at the hospitals, hospital beds, we should need to look holistically. That it's far easy for government to say that we have increased the bed. They can put the bed and they can create a building. But making those beds functional is a key part. And I want to give a concrete example. As an example, in India, there are 30,000 primary health centers. Now, each of those primary health centers has 6 functional beds. They are supposed to have 6 beds, but none of or very few of those facilities have a functional bed, which means that there are theoretically 6 beds available, which are counted in the government record, but never ever the patients are admitted. Never ever the patients are admitted in those beds because either doctors are not there or those beds have never been used. They are dirty. Their linens are not available or the supplies are not there. So essential or immediate requirement is that whatever is the capacity in the government healthcare facility, starting from the primary health center to district hospital or medical colleges, should be made functional. Sufficient commensurate human resources are provided. Just to going back to the PHC point, as an example, in India, there are 30,000 primary health centers, each has 6 beds, provision of 6 beds. If we can convert those 6 beds at each of the PHC, then it will make 180,000 beds which are functional. And if the oxygen supply, oxygen through the cylinders is provided those PHC, for the subsequent wave, India can have a 180,000 oxygenated beds which can be utilized. But it requires political will and commitment, and it also requires that human resources are deployed. It requires the medicines are provided. So it requires system approach, comprehensive thinking, and commitment. And I'm confident that if government commit, that is possible. But that commitment has to come with the seriousness, and which seems to be lacking. Even in the second wave, the government facilities have not been strengthened. As I said earlier, the response is most of times to the private sector facilities. We need to do more for strengthening government healthcare facility.
How do we create a new cadre which is sufficient? We already have Anganwadis, but they're overwhelmed. They can't do any more. We have about 10 lakh Anganwadi workers. How much of a force do you think we need, which is trained, which is not necessarily doctors and nurses, but maybe a paramedical force that can at least work on an emergency basis, that knows how to use these oxygenated beds?
So in this, there are 2-3 points. One is that there are already approved or sanctioned positions in the government at various levels. But in most of the states, especially North Indian states, those positions of health staff at all levels, which means doctors, nurses, pharmacists, radiographers, laboratory technicians, all of those positions are vacant, and that's why services are not delivered. Health sector is a service sector. You need a building, but you need more of to be attended by a provider, be it a nurse, doctor. So the first step has to be that each of the state government need to immediately consider fill in the vacancies which are there. So once those vacancies are filled, that's one step. But the other dimension of this is which require policy intervention, that those vacancies can be filled, but most of the government vacancies are filled on temporary or contractual basis, which essentially means people will join and then they will leave because there is no job security or no career progression. So government also need to revisit their policies. Most of the time, these policies were developed and the salary scales were designed 30 years ago, and they have not been revised. So that's why they cannot retain, government facilities cannot retain the health workforce. So it requires revisiting health service policies on retaining of health workforce, their salary structure. And third and final part I want to highlight is that in the recent years, Government of India has taken an initiative which is called mid-level healthcare worker through Ayushman Bharat program health and wellness centers. So these are the people who are less qualified or less trained than a doctor, but slightly more trained the field level workers. So they can provide some medication. They are being given some right to examine and prescribe medication. So they are community health officers or mid-level healthcare workers, and they are the norm in other countries. So India has started on that direction, but need to do more. This is called in medical language task shifting. Now, every patient need not to be seen by a medical doctor every single time, but India has not done enough on that. There is some start on that, but that need to be accelerated. So we require a comprehensive rethinking on the filling the vacancy, revisiting the policies, and task shifting or delegating. And there are many such ideas. That's what should be done, and those can be implemented over a period of time. So while we see a lot of enthusiasm in Indian states and even union level, but those enthusiasm fizzle out over a period of time. That need to be sustained. So we also need to think of institutional mechanism, independent institutions which guide the process under the political leadership and overall guidance of Ministry of Health. And final challenge here is that since health is a state subject in India, so the initiative or decision to implement these policies mostly lies with the state governments. And we know the appetite of state government and the financial capacity of state government vary, and that becomes a big limiting factor. We require more transformative thinking and some high-level political commitment to make a difference here.
You talked about the health and wellness centers. I think there's supposed to be 9,000 of them according to Ayushman Bharat, which means that there should be at least about 2 per district. Now, what are those? Are they built on existing health centers, or are they fresh constructions, fresh institutions? And if so, the cadre that is going to be created for that, how is that being trained, and how quickly can that be available, and can that be repurposed for the health centers? I mean, can it be one integrated system? The primary health center, the wellness center becomes one integrated system.
Thank you. I think this is really important question, which is partly understood in India. So India announced and launched the Ayushman Bharat program in year 2018. So this program has 2 components. One, which is very widely known and popular component and often equated with the Ayushman Bharat program, is Pradhan Mantri Jan Arogya Yojana. It's an insurance scheme for bottom 40% of population where people are provided insurance coverage up to 500,000. But that covers only the hospitalization related services. If person is admitted, then only person will be provided that kind of coverage. The second and more important coverage is health and wellness center. Now we know that the majority of health needs of population can be or are fulfilled by outpatient consultation, and that is the kind of services which are delivered through primary healthcare system. Right. We know, like most of the European country and national health services in UK is an example, that one need to be seen by a general physician before person can go to a specialist care, and that's what role of primary healthcare is. Worldwide, the importance of primary healthcare has been recognized. It had to be the foundation of the health services. Nearly 70% of health needs of population can be fulfilled and catered by PHC system, and that is an efficient way of delivering health services also. But what happens in India, that our PHC, primary healthcare system, is weak, which essentially delivers very few services. So people directly go to district hospitals. And so district hospitals are crowded with the people who need a general health services, and there are no specialists. So everybody who need a specialist services had to go to private sector, and which results in a high out-of-pocket expenditure, which essentially means people have to pay a lot. So fortunately and thankfully, Government of India recognized the importance of PHC in National Health Policy 2017. As part of that policy, there is a proposal to strengthen primary healthcare system. So these health and wellness centers are part of that initiative. Now, under the Health and Wellness Center initiative, Government of India has decided to convert the existing healthcare facility, which are 2 types of healthcare facility, health sub-center, which are around 180,000 in the country, and 30,000 primary health centers. So there are already 210,000 primary care facilities in the country. Out of those facilities, around 150,000 are proposed to be converted to health and wellness centers. So these include the existing facility, but these, when converting to health and wellness centers, it proposes a few things. One, currently the existing PHC facility, primary health care facility, deliver broad 6 type of services: mother and child care, infectious diseases, and other component. So as part of converting them into health and wellness center, the package of services is being expanded. So now onward, they will provide services for non-communicable diseases, mental health, geriatric care, ear, nose, throat, some ophthalmology services, and emergency services. So one part is that expanding the range of services. Second part is expanding the provision of human resources, and which also include this component of community health officer. Third part is establishing a well-functioning referral linkage. Fourth is providing a broad range of medicines and diagnostics in assured manner. Fifth component is attention on preventive or promotive attention. So health and wellness centers are essentially converting existing healthcare facility by broadening the scope of services, providers, some assured provision of services. And this 150,000 health and wellness centers were proposed to be available by December 2022. So India has developed or set up 70,000 health and wellness centers, but their functioning still need to be required, need to be strengthened. But it is going in the right direction, and that's the kind of approach we need to do: strengthen primary healthcare services by so people have access to healthcare services closer to them. They have medicines and supplies which they need. That will reduce the burden of district hospitals and medical colleges, and that's what.
Cadre, Dr. Lahariya.
The other cadre, so the only other cadre is a community health officer, mid-level healthcare provider. That's is coming, but there are no other cadre because health cadre is as part of the health being state subjective responsibility of the state government. So there are some health functionary, for example, auxiliary nurse, midwife at the health and sub centers, accredited social health activist, ASHA, which we hear a lot, and there are around 900,000. They, in reality, are not the functionary of health system. And as the name suggests, they are a voluntary worker, which are given remuneration based upon their performance at the work. So community health officer and mid-level healthcare provider is the only cadre which is being considered or discussed right now.
It's still not been created.
No, they are being recruited, but their number is still evolving because the existing staff or the group of people who are recruited for this position need to receive a 6-month training on specialized course, and then they need to clear that exam. And then they have a condition of serving at the facility where they are or the locality which from which they come from. So that is still evolving. Some progress has been made in that direction.
But we can expect it only by the time third or fourth pandemic hits us.
Well, yeah, that's a challenge. It's only one part of the solution. To make health services functional, you need to work on all levels. It's not enough that you work on primary health center. You need to have a continuity of care. It's a very human behavior that I will attend a particular facility when I know that I'll be given assured and timely care. And then if I'm referred, that referral will be respected at next level. But in the current system, if you try to improve only one particular component with a minor tweaking, it's not going to work. People over the years have a very limited belief or have lost that kind of confidence in government healthcare services. To bring that confidence back, the government health services need to do a lot more and show that they can provide end-to-end care, which means care at the facility, then referral linkage and the referral back, and providing the assured supplies and medicines.
Dr. Lahariya, let's talk quickly now at the end about vaccination and the availability. First, of course, the acquisition of vaccines. As you said, in the next couple of months, we will be in short supply. Hopefully by August, September, we will have more vaccines. Then the challenge is to get them to the places where they're needed most. Now, Doctor, it's not that we've not done such mass level programs before. We've had the eradication of smallpox, we've had polio being eradicated. So I'm sure we have some database where we were able to reach the last man or the last person possible. Why are we not repurposing that data and updating it to making vaccines available to all?
So one thing is that the first thing and why India is in this situation, that one of the core principles was forgotten, that vaccine delivery is outcome of 3 components. One is the vaccine policy, then supply, And third is the delivery. While there was a lot of attention on some policy formulation through a prioritization of various target groups, but insufficient attention was given on securing supplies. We know that India purchased very small number of doses 5 days before launch of vaccination program. So while there was a discussion that India need to vaccinate 300 million people by July 2021, that was our original discussion, while nobody or apparently there was not enough thinking to secure 600 million shots by July 2021. So that kind of gaps were there. And then delivery, India has an extensive experience, as you say correctly, from routine immunization program, which we call universal immunization program, where children are vaccinated and pregnant women are vaccinated. India has an extensive experience of polio elimination program, and then also measles and other type of campaigns. So country has a vast and long experience of delivering these vaccines. Had there been some more close attention to these aspects, we would have been better situation. We could have learned easily that the vaccination drive should have been opened as per the availability of vaccines. And alongside the vaccine, our supply should have been secured, and that would have made that a better approach. So there have been mistakes, errors. There has been not enough attention to learn from the past experience. We have a excellent infrastructure to deliver vaccines, which have delivered vaccines. As an example, in polio elimination program, though it was oral vaccine for children, but every single round, National Immunization Day, you to deliver 200 million doses over a period of 5 days. And we know the micro planning, we know the social mobilization structure of this thing. We have a strong cold chain infrastructure. So all the ingredients were there. What apparently was missing, sufficient attention on planning, the right kind of vaccine sourcing or purchasing policies and approaches, and the closer linkage with the right the good connection between policy and delivery approaches. I personally think that India has made a very complicated, convoluted vaccination policy, and that's why the current situation is that now everybody has spoken that vaccine in the pandemic should be at a single price for all level, like whether it's state governments, union government, or private sector. It should be free for the people, and they should be prioritized as per the need.
I mean, is it a failure of maths? I mean, you know that policymakers in India know the number of people we have in India. They know the number of people who need to be vaccinated. I mean, how difficult is it to understand the number of doses or the number of vaccines that were required? Why was a simple thing like this not thought of? And when you knew that America is doing this, the UK is doing this, I mean, there must have been exchange of information between policymakers across the globe, I'm sure. Why did we commit such a big blunder?
I think,
and I'm sure it's not a question of resources. A government can find resources when it needs to do something.
I think it is. It seems to be some of the technical experts were not given the free hand, and there seems to be more of a political interference at some places. We know that in April, second week, a senior official said that vaccines will be as per the need, not the want. And 10 days later, the vaccination drive was opened for all adult citizens. We knew that on 30th April and between 30th April and the next day on 1st May, the vaccine supply did not change, but vaccine beneficiary population or the target population for vaccination increased threefold. So starting 1st May, when there was already shortage a day prior, while the target population increased threefold, vaccine supply remained similar. So that's how we ended up in this situation. But looking back, there are three things. One, there seems to be insufficient attention to the technical advice of the experts by the political leadership, and that's why that is one reason. But also, I believe that Indian policymakers overestimated and had excessive confidence in the production capacity of two Indian manufacturers. What they forgot that vaccine manufacturing is a complex process. It takes time. and scaling up production capacity, even with the best of intention, does not work. So while manufacturers were saying that they will rapidly ramp up the capacity, policymaker apparently believed that, and they could not ramp up. So overconfidence in production capacity of Indian manufacturer was another reason. Then possibly, to be very fair to the policymakers, it was they had underconfidence in the demand for the vaccine from the government when they saw that even health workers are not coming for the vaccination. So they thought the demand would be relatively less, and that's when the when pandemic second wave started, the demand increased, things went in a different direction. But that's the role of policymaker, that's the role of technical expert. We need to be flexible and dynamic in the vaccination policy and drives. When we know that the supply is limited, then you optimally utilize, you clearly communicate and deliver to those who will need it optimal, not make a political decision to open for everyone when we know that there is not enough supply. When this decision was made, I tweeted, and it was widely read, that opening a vaccination for entire adult population is like inviting 100 people for dinner at your house while you have a capacity to cook for 20 people. You think that you can order in for another 15 people, but even then it will be 35 people. And if 100 people are invited, you know what is going to happen, chaos. And exactly that's what is happening, because you not enough meals or not enough vaccines, but more people have been invited, and it is resulting in disappointment. But biggest disadvantage, biggest setback of this approach is that the people already had a very limited trust in the government healthcare services, and I'm afraid that trust is being further eroded, and we need to do, and policymakers need to do something to tackle or bring the trust back in government health services.
It's all very clearly laid out, Dr. Lahariya. I hope the right people listen to your advice, and I hope we are not caught off guard yet again. This wave seems to not be going anywhere, but I hope at least by August, September, we look at a situation where at least vaccines are available. And also, I think the last point, Doctor, vaccines should be made mandatory, isn't it? Why not?
No, vaccines should not be mandatory.
Why
So
is
that,
that?
okay. So of course, in the particular period. So this is the debate on mandatory vaccination is
Yeah.
very age old, and of course, we know that vaccine is one of the tools out of many tools available for pandemic response. But at the same time, vaccines are administered to a healthy individual, and they do not come. They are not completely free of risk. There is a risk associated. So while from a public health perspective, it is important that as many people as possible are administered vaccines, but something which is not without risk, which is the case with the vaccine, there is a risk, even though minimal, cannot be forced on a citizen. And this has been debated in many setups and over the centuries, rather not only years, that when it comes with risk, I as an individual have a choice to make whether I'm willing to take that risk. In that setting, government's responsibility that convey to the people the benefits, advantage. But till now, there has not been any situation, even in the period of smallpox eradication or polio elimination. It's always voluntary. It's the responsibility of the state to convey to the people that what are the risks and what can be done. But without individual consent, because ultimately it's about my individual's health, vaccines should not be made mandatory. There are more nuance and other aspects. There are some religious grounds, and for example, you can make vaccine mandatory, but as an example, then it's forced upon me. There is where is the consent? Everything should be done with the consent. Even if people are sick and they don't want to take treatment, effective treatment, they should be allowed to do that. And other thing is, final part is that it will be a wrong precedence. If something is made mandatory, then it will set up, government will say that if this can be made mandatory,
Right.
then something else could be made mandatory. So there are illegal, moral, ethical, and issues which have been debated over the centuries. Never ever vaccine are mandatory and should not be mandatory.
But if people come forward for immunization of their children, as has now become the norm, why can the same philosophy, the same reasoning be used for this vaccine?
Yeah, so that's the same policy. So what should be done in any vaccination program? It's a because delivery is also linked to that conveying and communicating the risk of the disease and benefit of vaccination to the people. So information, education and communication is integral part of vaccine delivery program. And for example, there is a vaccine hesitancy, and this is a scientifically known fact, which has been reviewed by expert. In 2014, World Health Organization set up a committee on vaccine hesitancy. And they come up with a very great idea. They said that when we plot or when we put the individuals on a spectrum for vaccine hesitancy, so on one extreme, there would be people who would refuse any vaccine, no matter what evidence you will bring. They will say that I don't want to get vaccinated. There are like tennis players who say that they don't want to get vaccinated. And then on the other extreme, there would be people who would accept any vaccine. So, and most of the people fall in the middle range, which is, so our target should be ensuring that vaccine is available for each of the citizen who is willing to get vaccinated. In any case, there is not that many vaccine available to be made mandatory either, but it should not be mandatory. And then approach should be that on the left side, where there are people who are little hesitant, for them, their concerns need to be understood. The community and field-based study should be done, data should be collected, that why they are apprehensive. And those should be the messages through the communication strategy that to tackle there. So some of them will be converted. We want a high number of people to be vaccinated, but it's not necessary that each and every person is vaccinated. Even achieving 70%, 80% target would be enough. And there are more takers than 70, 80%. The number of people who absolutely refuse vaccine would be less than 1% and 1.01%. And of course, let them decide for themselves.
Right. Thank you very much, Dr. Lahariya, for your information, wisdom. I do hope that it reaches the right quarters.
Thank you very much. The pleasure is entirely mine.
भरोसा नहीं मुझ पर? डाउट है? तो वाइप करो. Savlon Germ Protection Wipes.